We are live.
Good evening, all. Welcome to iFocus Online, the 339th episode, 14th in the Oculoplasty module. Today, we have with us the very vibrant Dr. Shubhra Goel from Apollo Hospitals and Clinica 5, Hyderabad, to speak to us on dermatochalasis, blepharochalasis, and upper eyelid blepharoplasty. Dr. Shubhra Goel has her fellowship from Shankar Netralaya, Chennai, long-term fellowship from the University of Wisconsin, started by Dr. Dorsbach, the godfather of oculoplastics, trained under the leading Beverly Hills oculoplastic surgeon, Dr. Cynthia, and the world-renowned celebrated dermatologist, Dr. Zain Obaji. Presently, she serves as a co-founder and CEO at Clinica 5, an eye and face enhancement clinic, and for Foresight Limited, a medical and education initiative in Africa and the Middle East. She is an award-winning celebrity, a gold medalist, bestowed with the American Academic Achievement Award 2016, Indian Ophthalmic Heroes Award by the All India Ophthalmic Society in 2016 as well, Innovation Award and the Women Hero Award by the Women Ophthalmic Society of India. She is one of the only 7 doctors from India to be inducted into the American Society of Ophthalmic Plastic Reconstructive Surgery, chosen as the top 10 women surgeons in India by the Women Entrepreneur magazine in 21 and 22. She is the first oculoplastic surgeon in India to be appointed as a trainer for Botox and fillers for the Asia Pacific region by the Allergan Medical Institute. She is also a key opinion leader, GMV Italy Plasma Plexer, the very first to own that machine in India. Publications in various prestigious national and international journals to credits, books, atlases, section editor, reviewer for various journals. She's a regular speaker who has conducted many instruction courses at numerous national and international ophthalmic and oculoplastic meetings. It's a pleasure to have you on board, ma'am. Over to you for the lecture.
Thank you for such a kind introduction. So let's get going on what we have to speak today. Okay, just give me a time to share my screen. Can you all see my screen? Is the screen visible?
Not yet, ma'am.
Oh,
yes, now.
Yes, now it is. Okay, yeah. Okay, fine. So let's go back. So thank you very much to all of you and to Dr. Honavar for the continued effort through iFocus to impart the knowledge to the budding ophthalmologists and oculoplasty surgeons. It's an honor and pleasure to be here and talking on one of my favorite topics, which is eyelid blepharoplasty, dermatochalasis and blepharochalasis, which kind of comes under the one umbrella of things, okay? So this is me. And if you want to follow me, these are my Insta handles and also my website. You can get in touch with me because we conduct courses regularly for people who are interested to learn various parts of aesthetic practices in oculoplasty. So you can get in touch with me. Nothing starts without thanking your mentors. So I have been blessed to have the mentors from all across the globe. As mentioned, from Shankar Netralaya, which is my alma mater. Then I've had a privilege to be with Dr. Kat Burkett, Dr. Mark Lucarelli, Dr. Lemke, Dr. Brodsbeck, Dr. Cynthia Boxer, Dr. Obaji, and they are my pillars. And I am what I am today because of their, mentoring. So apart from what we are going to talk today, I thought, let me just take the topic a little off track because it's 8 o'clock in the evening and no aesthetic topic should be boring, right? It should be all interesting. So yes, we are all oculoplasty surgeons. We love to do what we do. But apart from that, I love my babies. These are my Shih Tzus who are Aloo Tikki. I'm a vegan athlete. I love to do interiors whenever I'm not working. It's just my passion. I love to travel, meet different people, and work on inner self quite a bit through different processes and courses. So aging is a fact of life, but looking your age is not. And unfortunately, in India or in most parts of the world, people think aging is just part of aging and we should age gracefully. But yes, you can age gracefully, but there are means and methods by which you can still look fresh, young, youthful, and have better emotions on your face and not look tired, sad, and run down by life and the stresses around it. So this is one of the shot which was shown to us in one of the ACE Opus meeting, I think 4 years back, by an artist who was trying to explain the various facial expressions and emotions through an artist view. Okay. So if you look at this picture and given the shots on the side, that anything on your face or everything on your face is dependent on two circles, which is periocular and perioral. So if you change the expressions or the structure around the eyes or around your mouth, the whole face changes, your expression changes. So that's what we are talking about today, about the upper eyelids. There is always a difference between, as I was mentioning, beautification and positive aging. So beautification is vanity. You are beautiful. All of us are beautiful. We want to make it more beautiful, and something is called positive aging. So I believe in positive aging, which in turn brings us to beautification. So let's talk about the upper eyelids, or the topic which I have been given to speak upon. The upper eyelids, or the lids and the brows, what we are going to touch upon is the foundation of the upper face. We all know about it. And if that foundation is weak or is not well developed, it changes the facial expression. So for example, now, if I'm just like this, okay, I hope you can all see me. I don't know in the recording if I can be seen. But if I just keep my eyebrows a little stretched, frowned, I would look very angry. If I'm like, my eyebrows are down or heavy, I look sad and tired, right? So based on where your eyebrows, where your eyelids are, it kind of defines your facial expressions in the face. And we can get all types of eyelids and eyebrows when we look at general population of people, okay? So they can present to you in different forms and formats, whether it is just a generalized aging or a disease, or somebody has had any kind of problem in their lifetimes. So this is one of my patient who we did some procedures, and I would post this question to my fellow colleagues here who are the budding oculoplastic surgeons. So what do you think has been done on her face? And these are real-time pictures, no filters have been used. One was taken by me, one was sent as a selfie after the surgery.
One is definitely the skin texture.
Mm-hmm.
The right side one looks more rejuvenated.
Mm-hmm.
The left side one looks little
Mm-hmm.
run down and worn out. Another thing I can see is the under eye tear troughs, which have been effaced in the right side picture.
Mm-hmm. Mm-hmm.
That actually brings her eyes like more beautifully out in the right picture. And then in the left eye, obviously she's looking more tired. And I think something around the oral region also, because the lips here, the area, it looks little like down with the gravity. In the other one, it looks little lifted up.
Anyone else? Good. That's some of the good points. No. So do you look at her upper eyelids and brow positions? Okay, so now just try to cover with your hand below, just keep your hand or palm on the nose and just look at her eyes and the brow area in both the pictures. So if you cover her nose way down with your palms on the screen, just focus on her upper eyelids and brows, you will see a rejuvenated look. Okay, the expressions have literally changed. Apart from what you narrated, Shefali, of course, she had some amount of other work done, but it is mainly her upper lid bleph and the brow position, which has been worked upon mainly in addition to other things. So the point of putting this picture here is that you can get the wow effect by working on the areas which look troublesome, which look tired, which look not so okay. Okay, so let's look at different cases. Now I'm just going to take you through different cases which you will see in your normal practices. I'm not going to put cases which are vanity cases. These are cases of general people walking to us, complaining about what they're suffering from. So this gentleman came to us because he feels heaviness on his lids. He feels a little tired. He's not able to see clearly. He feels whenever he tries to read, he has to force his eyes to be opened. So any one of you, Tithi, can you just brief me and tell me what are the, just quickly, 1 or 2 things in the periocle? Don't go anywhere else on the skin and mid-face and all that. That is separate class, but just focus on your lids and brow position because that's our topic today.
So there's there's dermatochalasis in his right eye and also a bit of brow ptosis, which is why the cornea is getting covered on the upper part, which is probably why he was having difficulty reading.
Anyone else? Okay, so if you look at him, he has ptosis. He definitely has involutional ptosis on the right side more than the left side. He has true and false dermatochalasis. That's what I was looking for as an answer, because a gentleman who has a strained forehead, if you see there, he has rhytides on his forehead. And if you look at the lateral picture, the brow is down. So he definitely has a lit skin, which is not okay. So there is a true dermatochalasis and there is a false dermatochalasis. For people who are postgrads here and don't understand what is dermatochalasis is nothing but the extra fold or hooding of the skin or the fat which happens either on an upper lid or the lower lid. So this is a case where we would be assessing the patient in terms of the brow position, the upper eyelid skin, the fat pads, and the lid position. Also remember, whenever you're talking about blepharoplasty is not a single entity, whether it is upper lid or lower lid, and I'm sure Dr. Kasturi would have covered it yesterday in her class or day before. We always look at it as a complete unit, okay? So upper lid is a unit with your brow and forehead, and lower lid is your unit with the cheek and mid-cheek. So always look at that in totality whenever you are treating or assessing the patient. So another case, similar kind of a case in a woman, you see how much of lateral hooding is happening over here. So that kind of a skin is completely like a curtain on the lateral hooding, which is obstructing. You can see there are no lashes also seen in the lateral view. So this is like a grade 3 to grade 4 of hooding where the lash line is also covered. So it kind of covers the visual field for the patient. Patient cannot see the temporal field of vision in addition to the cosmetic outlook, which is not so happening. So this patient also, and if you look, the brows are very low set. The brows are not in the right position for a woman to be there or a lady. So when we consider this case, again, this is a case where we would have to work on her brows and we will have to work on her upper eyelid skin. These are different cases where you can see from the picture, these are cases of facial nerve paralysis. So in facial nerve paralysis also, patients can present to you with droopy lids, extra skin on the lids, and different problems. So in facial nerve paralysis, the key point here is that would you really like to go ahead and do any kind of a surgical procedure or not depends on the health of the eye, the health of the cornea, how much is the amount of lag ophthalmos and so on. Even in facial nerve paralysis, I have done cases where we have done blepharoplasty, we have done brow lifts, and we have done other procedures to help the patient balance the functional and the cosmetic outlook. Okay. Now, these are the patients where I just wanted to focus and tell you how much of forehead constraining is happening, how much of forehead is actually overacting, the rhytides, the heaviness. So there's a lot of forehead ptosis happening, which is literally flattening the brows. You see in this picture of a lady, the brows are almost like a masculine brow, which is flat and down slanting, whereas in a female or a lady, the brow should be arched and little upward. So this is also a sign to tell you the facial aging, where the forehead is down, muscles are contracting, brows are down, and in turn you have the lid and upper lid changes. Okay. So I want to bring your attention now to this gentleman who was referred for upper lid blepharoplasty because patient knew that he has a hooding, but something very interesting happening over here. There is a fullness on the lateral part of the eyelid. Another girl who's a doctor by profession walked in and she said, I have a bulge in the lateral part of the eyelid. And this is what you see. So can anyone tell me what are these? What are these bulges in addition to the skin fold, which you can see in the gentleman?
Steatoblephron, ma'am.
Steatoblephron. Okay. How would you see a steatoblephron from the skin side as a bulge?
Prolapse like lamellar gland.
Yeah.
Yep,
So these
exactly.
are conditions of prolapsed lacrimal gland. And when we open, this is how you can see it popping out there. So don't miss out these conditions when you're looking at a patient with dermatochalasis, because it can be hidden under the skin. These are the cases of, so this is the case of blepharoplasty. I just want to touch upon blepharoplasty briefly. It is not so commonly seen in India, yet seen. And this is a condition which can be congenital, which can be idiopathic. Condition starts early in the age, can progress up to 30s and even 40s sometimes. There are no reasons why it happens. We all know sometimes it is self-limiting. And this is a very classical skin type which you will see in patients where there's a young patients having a very loose, thin, papery skin, and they will present with true dermatochalasis. So this is one of the ladies who, and I'm going to discuss her case as a very challenging case at the end of it. And this is another gentleman who was referred to me saying that, I'm not having clear vision. So if you notice, most of these patients will come to you not complaining of a hooded skin or a hooded eyelid. They would complain that some heaviness is there on my eye. There's something obstructing my vision, and that's why I want to do something about it. Most of them don't know where to go, what to do. So we need to see these pictures clearly and understand what's happening, okay? Another case of blepharoplasty on my right, which is very classical, thin, papery, cigarette skin. And this is the old lady, a classical example of how a grade 4 facial aging can cause multiple changes, whereas again, their ptosis is thin. So the difference between blepharoplasty skin and an old skin is why this picture has been put here. So in a young patient, a blepharoplasty skin can actually look like a patient's old skin, right? It is very thin, it is papery, it is very textureless, the collagen has gone, whereas in an old patient, it is an old patient skin. So these are the examples where you would try to understand and notice what are the different kinds of dermatochalasis, what are different kinds of skin laxity, what is the different kind of hooding and conditions which are leading to it. And this is a very classical case of people from northeastern part of our country, where they don't have any lid crease, they have an anteriorly placed fat, and they have an Asian look. And it can also present in different formats, right? So this is a gentleman who is not from a northeastern part of it, but his eyes are looking like Asian or northeastern look, where the lid crease are not uniform. It is forming at a different level. The lashes are a little bit down slanting. And these are kind of challenging or, cosmetically challenging cases which you need to deal with, okay? So when you're assessing a patient, there's a lot which go about in assessing a patient, apart from the general or systemic or body checkup and the ophthalmic checkup. These are the first two things which we have to finish before we jump into the facial assessment. A lot of us forget to do the ocular examinations or ophthalmic examination and the systemic examination, and we jump into the facial assessments. So facial assessments, you have to look at, as we were discussing, forehead ptosis and rhytides. We have to look at, brow ptosis, skin and mobility. We have to look at the dermatochalasis, gland prolapse ptosis, as I have shown in different pictures. So I think now it is easy for you to understand. And of course, we look at face in general if you want to do anything else for the patient. Because we are going to talk about the upper lids and brow, I'm going to restrict my talk today to that area, okay? So this is another scenario with, of a lady who was referred. So what do you think she has? Does she have dermatochalasis? Does she have ptosis, or does she have brow ptosis?
Brow ptosis, ma'am.
Yeah. Yeah. So if you just lift her brows or simulate her brows, you see the lid margin is exactly where it is supposed to be. There is no extra skin which needs to be removed. And this is a patient who needs only brow lift and not any kind of a blepharoplasty, though it looks like a hooded eyelid. Okay. Another girl who was referred, if you look at her right, on the screen, the right eye is mildly ptotic. If you look at her brow positions, the brow positions are not even uniform at equal positions. She had multiple intraocular surgeries in the affected eye, including the retinal surgeries. And she walked in saying that my right eye is looking ptotic, but she was constantly pointing on her brow, that her brow is down and she wants something to be done. And we just did a little bit of Botox to play around to bring her eyelid in position. So what I'm trying to show by this case is that Blepharoplasty, dermatochalasis, is just not skin and muscle and fat to be removed. You need to understand the case in totality before you approach such patients. Okay. So before we, as I mentioned, you have to take a complete history of a patient. What is patient suffering from? What is it? Where are they coming from? What is their occupation? Any systemic disorders? Have a complete ophthalmic checkup, facial assessment. And when you come to the specific examination, you look at the brow ptosis, measurement ptosis, lid and skin and other components, which we have already discussed. A counseling and a consultation is of paramount importance in any of these patients, whether it is a functional oculoplastic case or a cosmetic oculoplastic case. Even if we are doing blepharoplasty for functional reasons or cosmetic reasons, it is very, very important to sit down with the patient and explain them and make them understand about the realistic expectations and outcomes. Slight asymmetry is not a disaster, has to be told to them, because we are asymmetric, so they should not be expecting picture perfect results. As I said, communication is the key. Document, because it's not only essential for you to go back and check what the results are, but also to show to the patient, and also from a medical legal point of view. And I'm sure all of us know about it. And then comes the planning based on where the patient is coming for, what the treatment is required, what we have planned. We can take the patient for the surgical or non-surgical treatment. So I've already talked about realistic outcomes because I stress upon it, because people expect something out of the blue, which is not possible. And we need to have a very strong post-operative care and a scar care in any of the surgeries which we are doing, and I'll come to it a little later. Ask about systemic medications. One of the most important thing, any form of anticoagulants, whether it in terms of allopathic medicines, Unanis or Ayurvedas, they need to be stopped, because we don't want any secondary hematomas or problems after the surgical methods. So we have already covered this. I'm going to skip that. One word on skin, muscle, and fat is what I'm going to touch here, is that how do we decide whether we are going to do a surgery which is going to be only skin removal, only skin and muscle, or with fat? And that we will come to the discussion a little later. So this is how you check for, this is a patient who has a true dermatochalasis and a false dermatochalasis or a pseudo dermatochalasis. And how you check for how much is the brow ptosis is by simulating the brow upwards. How you take your levator action. In similar manner, you just lift the brow up and see how much the excursion is happening, and that is the amount of brow ptosis. So if you look at this gentleman, when I lift the brow, the dermatochalasis is not so severe, right? It is more of the skin hanging because of the brow. So of course, along with your blepharoplasty, the brow also has to be corrected. Don't miss out on lid laxities. Most of us miss out on this point, because if the lids are lax, any kind of lid surgery you do, especially blepharoplasty and ptosis, patient is always going to complain and not happy about it, because the dynamics of the lid is still not okay. So you need to bring the dynamics of the lid back in position, and you need to tighten the lids wherever they are in that position. Okay, so let's go step by step on a short videos on how we do the surgery. So the first important thing, once you have decided, now this is the candidate for upper lid blepharoplasty, is the skin marking. So on an average, we need to spend, I spend at least half an hour to 40 minutes sometimes to mark my skin incision, especially in upper lid blepharoplasty, because one wrong marking and one wrong cut can lead to a lot of asymmetry and unhappy patients. So you always make note of where the lid crease is sitting. You always use the right kind of a marker. Look at the various pointers which I'm going to talk about, how we mark the upper lid blepharoplasty markings to incise that skin, and then do it slowly. Okay, so the important thing is that you always look at the lid crease, see the lid crease. If there are multiple lid crease, you always look at the inferior most lid crease and take it as your benchmark. There is always a lateral hooding which we need to do, and you stop at the medial puncta. I'm going to show all this. You have to maintain the brow fold distance, consider the brow gravity. So keep simulating it and see how much of the extra skin is happening. And a minimum of 20 millimeters of skin is what we leave behind. So see, if you have multiple lid creases, we will measure in general how much is the lid crease distance, which is usually 7 to 8 millimeters in women, 4 to 5 millimeters in men, and sometimes it can vary. So you mark that, you take a lateral flange, which should be around 10 millimeters from the lateral canthus. And you stop at the medial puncta, and then you can do a pinch test or a pinch technique to see how much is the extra skin. And then you measure, because the amount of skin which should remain between the upper eyelid or the lash margin to the lid brow skin junction should be minimum 18 to 20 millimeters, because that's the amount of skin which we need for a normal closure of our eyelid. So if you see now, we're just pinching it. Though there is a lot of laxity of the skin here because of the poor collagen, we are not going to remove it a lot. So now you see there's a 20 millimeter thing. Okay, could you see that? Or I should show you again. So if you see this, once we have marked it, okay, that's a lateral flanging, and we are pinching it. That's the amount of skin which is going to come out from the lash to the brow and skin junction. It is 20 millimeters. Okay, so this is a worm's view which we're showing you. So this is where medially it stops at the medial puncta. It goes along the lid crease, and there's a lateral flanging which is around 10 millimeters from the lateral canthi. And this is how the skin incision will look. This is again a pinch technique to show you how much of the skin you can remove. Whenever you're pinching, just a little bit amount of eversion of lashes, just a mild amount of lag ophthalmos is okay. But if it is more than that, that means you're going ahead, you're removing extra amount of skin. And as I mentioned, 20 millimeters from your lash line to the lid and brow junction, skin junction, not the brow, but the skin of the brow and the lid where the junction is happening is around 20 millimeters. Okay. Another picture to show the similar facts. So this is a picture which will give you a even more clearer version of it. So there are some set markings which we follow, that from the lower end of the lateral flange should be less, around 5 to 6 millimeters, and the highest point of the lateral flange is around 10 to 15 millimeters. And it varies in patients with severe lateral hooding. If there is very, very heavy lateral hooding, then we can even go a little lateral and remove maybe beyond 15 millimeters. Okay. So this is again a picture showing that if you see the second picture, that's showing you 5 millimeters from the lateral French end to the lid margin. That should not exceed, because that's kind of maintaining the contour of the lid. And then if you look at the lateral most or the uppermost flange from the lateral canthi, it is around 10 millimeters. Okay. You can always have the W pattern medially to remove extra skin. There are various techniques to do it, but it doesn't really matter. Again, why am I showing these pictures again? If you look at this lady, we are also doing an external brow lift. We are simulating the brow to see where it is falling, letting the gravity act in the first picture, working against the gravity in the second picture, and looking it from the surgeon's perspective, where the eyelid margins are sitting, where the crease is sitting, where the brows are sitting. So give time to the lid crease, the markings for the upper lid blepharoplasty. Once you're experienced and you know what you're doing, it's fine to be fast, but I still believe no matter how good surgeon you are, markings should be done slowly, and you must take a lot of time to mark it. Okay. Now this is a video I want you to observe very clearly. Is it playing?
No, ma'am.
Yeah, okay. Anyways, this was a video to show about wrong markings versus the right markings. For some reason, it's not playing. It's playing, but not playing. So basically what had happened is that in this gentleman, I had gone inferior, thinking the lid crease is there, and then I corrected it. So it's just one of those. This is a kind of typical draping which we do for all the blepharoplasty patients. You don't want to do an ophthalmic draping because you want to do a facial draping. People who are practicing oculoplasty know about it, but people who are not, that's the thing for them, because if you're not doing that, you will not know where the position of eyelids in comparison to the faces. You don't want this area to be tight and covered with drapes. You want to keep it as loose as possible. You want to keep the area open because your oxygen tubing is here. And when you're using the radio frequency cautery, you don't want any spark of fire to be under the drapes. So this is how we drape. I'm going to stop here, but Yeah, a word on the local infiltration. Again, local infiltration, there are different methods which people use. I use lignocaine, sensocaine, mixed with Hyles and Dexa. So you can use 1cc, 2cc syringes, whatever you like, 26 gauge, 30 gauge needle. Basically, the idea is that you stay in the suborbicularis plane and inject very slowly to just lift that bleb up of the skin and muscle. Okay. And this is called the hydraulic expansion of the skin and muscle. You don't have to inject a lot. And around 0.5 to 1 cc max is what you need for upper eyelids. You don't need more than that, even if you're doing the fat excision or the muscle excision. Okay, then massage and wait for 4 to 5 minutes for things to settle down. Don't be in a hurry to inject and operate, because you need a good hemostasis. You need the planes to be ironed out. You don't want bulges. You don't want heaves and creases for your excision and incisions to be done. Okay, so you see my plunger, how slowly it is moving. So you have to be very patient in these steps when you're doing, and then you just wait, massage gently with the hydraulic pressure here and there. And once the skin is settled down and the ballooning effect is gone, you can start the process. Okay. So you can use a 15 number blade, or you can use an RF cautery. I use a Colorado tip and an RF. I'm pretty comfortable with it. You can use the machines with you like, Elman and other companies. No financial interest in any one of them. This is a simple case of a skin excision and not skin and muscle, because the patient is young and just had this skin laxity and no muscle was needed to be excised. So I'm going to repeat these steps to show you what I'm doing. So we stretch the skin and we keep it on a stretch so that we know where we are injecting. Very, very slight feathery touch incisions are given. You don't have to really cut the skin, and let the skin just stretch apart on its own, because the skin will just stretch apart. And then you have these scooping movements to just remove the skin away from the incision side. That's the best way to do it. So you're scooping it from out in, and then the flap comes out. Okay. And then it's a simple thing. Once it is all done, you can just, look at the areas where you see if there are any dog ears or anything. And I prefer to take running stitch with 6/0 nylon. Some people take Proline. We can take absorbable sutures also if you intend to do that. If it is only the skin excision, I don't do the lid crease creation, because we have not disturbed that. But if it is a faint crease which you want to reform, especially sometimes in Asian patients where we're just doing the skin excision, we will have to do that because we want to form this lid crease. And this is how it looks at the end of the procedure. Okay, so again, this is a picture which says that you start from the lid crease, stay on the skin superficial, follow the markings and go slow. Okay, this is one of the techniques which I learned in my fellowship, where the picture is a little blurred, but if you have only skin and muscle removal and not too much of pre-epineuritic fat to be excised, I'm going to come to the fat pads later. You can just use the diamond burr tip of your cautery and just kind of shrink the whole muscle and fat backwards. And that kind of gives a very, very nice contour to the upper eyelid. A word on dog ears. If you get dog ears, this is how we excise it medially. Laterally, of course, you're not going to get it. There are different ways. One is a triangle technique and one is a W technique. I am not a big fan of W, but if it is happening, this is usual triangle technique is what we follow. So now word on your pre-epineuritic fat pads. On the upper lid and lower lid, it's different. I'm not going to talk about the lower lids, but the upper lid, we have the medial fat pad and the central fat pad. Okay, the central fat pad is a bigger one and the medial fat pad is a smaller one. The difference between the medial fat pad, the trochlea of the superior oblique kind of separates these two. The medial fat pad is more firm, more whitish and more difficult to chase and more dangerous because the blood vessels are coming there. So you have to be very, very careful for its prolapse versus the central fat pad. Okay, whenever we are dealing with the fat pads, you kind of let them pop out easily, whatever is coming. Don't chase the fat pad, let it just pop out as a baby pops out. You clamp it, cauterize and cunt it. You can sculpt more than excising. As we know, redistribution of fat, sculpting is now the in thing, whereas in olden days we used to cut. Yellow versus white, I have already told you. Yellow is basically your central fat pad and white is your nasal fat pad. And we use the monopolar cautery to do that. Okay. So another picture to show you how the trochlea basically separates the medial and the central fat pad. Okay. So another picture. Okay. So here what we are doing is we are removing now. So this is about the fat pads. Now this is a picture where we are removing the skin with the muscle. So you see, you can actually see the aponeurosis out there. I don't know if I can use this. Yeah. So this is the yeah. You can see my laser pointer on the screen.
Yeah.
Yeah. So this is your skin with the muscle flap, which has been removed, and this is your aponeurosis. Okay. So this is how the white aponeurosis will be seen beneath. This is a patient where the skin and the muscle flap has been removed. And this is how we clamp the fat. And when we clamp it, we cut it. Here the blade has been used, but we can always use the cautery to do it. One assistant would put the fat on the stretch because we want this fat to be stretched. Look for any vessels which are there, and then you can cut it. So always clamp, cauterize, and cut. So we are cutting it here, and then we are cauterizing it. Okay, so this is a nasal fat pad which is deep enough. So make sure there are no bleeders when we are cauterizing and cutting it. Okay. Remember, for a proper hemostasis in any blepharoplasty surgery, whether it's upper or lower, you can use monopolar needles or bipolar cautery. You have to make sure none of the edges of the orbicularis muscle is bleeding. On the lateral side, keep a lookout on the lateral palpebral artery, and of course the fat pads, because the worst complication in an upper or lower lid blepharoplasty is
Hematoma.
Okay, what else with hematoma will happen?
Yeah, loss of vision because of secondary to raised intraorbital pressure, secondary to orbital hematoma. Because if you're not able to find a bleeding vessel with a retraction of the medial fat pad into the orbit.
Yeah, so there is a retrograde flow of the hematoma which happens because these are open spaces, and you can have patients with intraconal compressions, extraconal compressions. So you have to make sure, and this can happen in first 72 hours anytime because the smaller capillaries can bleed anytime. So cauterization is the key here. Okay, let's go through some of the results. So any questions on behalf of you guys here who are representing the other set of people, and we can take the other questions later. Till this point, we have covered what is dermatochalasis, what is blepharochalasis, how are the different case scenarios being there, what assessment you do, what are the pointers which you need to take care of, how do you do the facial assessment, what are the various steps to go ahead with the surgical, whether it is skin, muscle, or fat, precautions, and so on. So any of the questions you have for me, and then otherwise I can go to the results and I'll keep discussing the results.
In cases of blepharochalasis, what are the precautions that we should take? Because we know that they have like a tendency for inflammation more. So even during the surgery or post-op, like early initiation of steroids or something like that. Because
blepharochalasis patient you should not touch unless the attacks, which is the recurrences and remissions, have not happened for at least 6 months. That's the key to touch those patients. If the patients have been having that recurrences and remissions, you're not going to touch the patient. That is point number 1. Point number 2, you never over-excise in these patients. You will undercorrect these patients because you may feel the skin is a lot. It feels like a heap of skin which you want to remove, but that's not going to help you. The more skin you remove, the more the skin is, because the problem is not anything else but the lack of collagen in the skin. Recurrence in these cases is very, very high, almost 100%. Okay, so you have to mentally prepare the patient. I'm going to show that case in the end, one of the blepharochalasis, which was challenging for me to do, which makes you understand that how things can actually go not so well in these cases, from not only from the recurrence point of view, but from the scar management, from pigmentation management, and so on. So these are the key pointers. So blepharochalasis patients are difficult patients to deal with, should be done only when you're trained enough and you've done some amount of blepharoplasties, which are simple blepharoplasties. and then you can take this forward, because even the incisions, the way you mark the incisions, where should your lower lid crease be, how much lateral flanging you should do, it all depends on the amount of skin which is there. Okay.
Yeah,
Okay, let's go ahead then. So as I was telling you, we may have a question that when should we just excise skin, when should we do skin muscle, and when should we do fat? Of course, it's a very simple answer. Now, if in a young patient, you will always do a skin unless the patient has a very, very hypertrophied orbicularis, which you can see. But if it is a middle-aged or an old patient, then of course you will go with the skin and muscle. Okay. And of course, when you are looking at the eyelids and you see the fat pads popping up when there is bulges around the eye, that is a signal that your fat pads are prolapsed and you have to remove it. So there's a very simple algorithm to it. So this is one of the patients. If you see, she just has a lax skin on the upper eyelid. The muscle is not so hypertrophied. There are no fat pads. This is a simple case of skin excision. This is how she looks immediately after the post-surgery. And this is after 2 weeks of surgery. The scars are still healing, and you can see the results are pretty good in terms of the laxity of the skin which has been removed. Nothing else has been done. This patient is just a pure, simple skin flaps, no muscle flaps taken. Okay. Whereas this is the patient, if you see, looks like has a left eye ptosis, very heavy on her eyes. You see there's a lot of heaviness on the subbrow area. The skin is heavy, the forehead is heavy. So she is a candidate for skin and muscle flap, along with any fat which will push out. So if you look at here, there is a little bit of fat prolapse, and central fat prolapse definitely is happening. So we went ahead and did her surgery where she still is edematous here. This is just 1 week post-op. Now, why am I showing you 1 week post-op? Is these are the reality cases that you'll see in your blepharoplasty patients, because the end results will come only after 4 to 6 weeks. So you have to deal with patients in a very, very slow manner, in a very patient manner. You may need some touch-ups in some of the patients in first week, if at all, because some of the fat pads may redistribute and come forward, and be ready for that, okay? She's my mother, so she's a thyroid patient. She has an upper lid. So you see how heavy her eyelids are. There is a fat prolapse. There's an upper eyelid skin. Her brows are hyper-exaggerated because of her, frontalis overaction. She has festoon, she has lower lid fat pads. So this is how she looks after like 4 to 6 weeks. If you look at her, I've not over-excised her skin. I've just done a little bit of touch-up and smoothing, and little bit of touch-up and smoothing on the lower eyelids, because you want to maintain the realistic features of a patient. You don't want to make them look suddenly too done. Okay. This is a gentleman I had shared the picture before. So there's a hooding, and here we just went ahead and did a skin and muscle flap. No brow, nothing, only skin and muscle flap. And this is how he looks after the healing process. Okay. A word on blepharoplasty and dark circles. Sometimes the patients may present to you with dark circles like in this female. And if you look, there is a laxity of the upper eyelid skin, and there is a laxity of lower eyelid skin. So this patient came for dark circles, but we went ahead and did her upper eyelid blepharoplasty where the extra skin was removed. You see the shadow effect has gone down. Of course, I have a better picture of her once we started the skincare. I didn't show it here because that's not the topic of interest today. But now with her skincare, her dark circles have completely vanished. So sometimes the indication for patient walking into your office may be a little different from what you think and what you have learned. And you may have to understand what the patient is requiring from you, because the laxity of the skin also exaggerates the dark circles because of shadow effect. Okay, another lady, purely lateral hooding. Again, this is a case for skin and muscle excision because it's very heavy skin and muscle. Medially, she's fine. There is no fat prolapse. And this is how she looks. She has a pre-existing ptosis, if you see here, which we have not corrected. We have just left it where she is. Most of these patients, when you see, we are not changing the features. We're just maintaining what they are and giving them the natural looks. Okay. This is one of the patients, which is a typical Asian blepharoplasty. Again, we have created a lid crease. We have maintained her look. We have not changed her from Asian to Caucasian. She still has a little bit of fullness, and they prefer to have it this way because, of course, you have to ask your patients what they're asking for. If they want a very deep lid crease and they want to look Caucasian, so you can go ahead. But this is a word on Asian blepharoplasty is that this is a little different from the normal blepharoplasty, because here the lid crease is little anterior and not formed. The fat pad is placed anterior. So you have to open it, remove the fat pad, which will be almost to sitting on the tarsus and not into the septum. So you remove that. And then the key here is how much of the skin has to be removed, because these patients mostly have good collagen. But in the younger age group, but in the older age group, the collagen kind of depletes and has more dermatochalasis. So your incisions will change accordingly. And the most important step in these patients is forming of the lid crease. So there are different techniques to do it. And the lid crease has to be formed by taking the anchoring point on the tarsus. Some recurrences can always happen. Okay. This is a gentleman we showed, remember? So this is of skin alone. Here's a case of asymmetrical lid crease. See here, the lid crease is good, but we kind of exaggerated the lid crease and brought the other eye also to the same level so that he looks symmetrical. Now the patient with Eyelid Blepharoplasty, here we see the more skin has been removed, because look at the amount of flanging she is happening laterally. So the skin and muscle flap has gone laterally. We have even crossed the lateral border along the lateral brow because we want to lift it up a little bit, and this is how the patient looks. Another case where there is asymmetry of lid crease, there is asymmetry of skin, we have kind of aligned it, and this is how the patient looks at the end of the surgery after around, I think, 2 months or so. So we have to work around on maintaining the lid crease, how much amount of skin has to be removed. So it's an artwork. You're kind of an artist who's painting the face again. So you have to go slow, go do it with your principles in mind, and go ahead and do these procedures. So this gentleman is a case where there is a forehead ptosis. There's a lot of heaviness. You can see this forehead rhytitis. So he's losing his brows quite a bit. He is a case of pseudo and true dermatochalasis, but we just went ahead and did skin and muscle and just let the little bit of lateral hooding left. And you see the moment we do that, there is a relaxation on the forehead in terms of his rhytitis and the overaction which is present. And some amount of lateral hooding is good in men because you don't want them to look feminine and you don't want them to look overdone. So this is kind of a natural look, okay? She's another patient with a very early attacks of blepharochalasis in her age, in younger age, because she did have recurrences. You see the texture of the skin is so different here, right? It's not like a true, skin laxity. And this is how the patient looks after the blepharoplasty, upper lid blepharoplasty. Again, no brow ptosis, brow lift was done here. This is another patient where we have worked on the lid creases and the skin folds and brought it together. Again, we have concentrated mainly on the skin and muscle flap and balancing the lid creases. Okay. Okay, this gentleman, you see a huge amount of skin and muscle. There is a little bit of fat prolapse here. And he could not come back for a review. So he sent his selfie, and this is how he looked, pretty happy with his looks. Always remember, you're not changing the looks, you're softening the looks. So maintain the natural look of a patient the way it is. Blepharoplasty does not mean you excise every bit of skin and every bit of fat. Blepharoplasty means you're smoothening the look for the patient. So please remember that fact, okay? This is another patient. We could not take her pre-picture. At that time, she didn't want us to take. She went to US. We could not take her post picture. So this is how she shared her pictures of how she looks pre and post with both upper and lower lid blepharoplasty being done, and pretty happy patient. Okay. So any doubts from any of the cases which I have discussed till now? If you want to ask me any questions, please feel free to ask me.
I think go ahead, Shubhra.
Yeah, okay. Ma'am, the clinical differentiation between the skin muscle, a case with requiring a skin muscle excision versus skin muscle and fat. Can you re-explain that once, ma'am?
Okay, so let's look at these cases again. So if you look at a case like this, okay, this is just a pure skin and muscle. There is no fat here.
Yeah.
Okay, there's no fat prolapse. But if you go to a case like this, you see there is a fat prolapse here. So much of fat, so much of fat. This is all hooded skin. The fat is gone. You see, there is a fat prolapse here, which is gone. So when you open the lid, when you open the septum, the fat would just come out. You will know it. So when you're doing your skin muscle flap, you are on the septum and you just press the globe, you'll know if the fat is excess and it will just pop out because the septum is already opened up. In patients who have a fat prolapse, the septum is already opened up. You don't have to open the septum. It's already open. That's why the fat is pooling out, right? If the septum is intact, the fat would be behind the septum. You'll not see the fat pads. So the moment it pushes out, you have to remove it, and clinically also you can make it out, okay? Even in this lady, there is a fat pad here, fat pads here. Now this is a sub-brow fat. That's a fullness. You can't remove that. That you can't work upon, okay? This is a simple skin. They're not even muscle. You see, there is no muscle. It's just a skin. It's just a lax skin which is present here, not even a muscle. So you just go ahead and remove the skin from here, okay? This is again skin and muscle, because in a man, it cannot be only skin. You'll see how heavy and robust that hooding is present. This is again only skin and muscle. Skin and muscle, of course, and fat a bit. This is only skin and lid crease. This is, of course, skin, muscle, and fat, all three of them, because in Asians, we know that the fat would be sitting downwards. This gentleman is only skin and muscle, and I think there was a little bit of fat in him here. Central fat pad was pushing out. This is again skin. And this gentleman also, you see, there is a fat pocket here. You can see it here. The fat pocket is here. Yeah. Okay. This lady also, you see, she's a thyroid patient. There's a lot of fat pockets which are gone now. Isn't it? Lower lids are looking amazing, actually. Okay. Fine. Any other questions? Okay, so let's go to the complications of sequelae. There is a difference between sequelae and complications. Complications, as you know, can be hematoma, can be infections, can be diplopia, only in the lower lid, not so much in the upper eyelid. But the and ptosis because you have actually gone and hampered the levator, or you damaged it while opening the muscle flap, or you went too deep, and it can happen in initial cases. It's okay. Whereas sequelae is something like ecchymosis, wound adhesions, scar abnormalities, epiphora. These are the sequelae. So you have to differentiate between these two. The acute or the complex problems are your complications, which you have to be careful. They're usually intraoperative. Sequelae is what happens after the procedure, like scar abnormalities and, wound adhesions and pigmentation and asymmetry of lid crease. It's not a complication. Lid crease asymmetry is a sequelae which you can always go back and correct. So you have to just be careful about these things, okay? These are pictures of my mom. Again, I just wanted to show how a patient can look after the surgery. So patients have to be ready to see how they will look. So this is mom. This is immediately after the surgery on table. Then she kind of started swelling up, and then she came to where we saw her. So we have to prepare the patient for the post-op recovery from day 1 to day 7, and that will differ from patient to patient. So we need to show them. This is a lady who's immediately, this is how the patients will look. They may get actually scared sometimes. So you have to mentally prepare them of how they're going to look. The scars. This is a patient who had the upper lid bleph and a little bit of brow lift here. You see, there are scars here, but these are the scars which have healed. And if you look at her post-op, you can't even see the scars. They're beautifully blended into the lid crease, and it looks as if nothing has been done. So the scars actually heal beautifully versus some of the scars which may not, and they can be very tricky to heal. Okay. So this is one of the challenging case which I wanted to show you. This is the lady which we discussed, a case of blepharoplasty. I went ahead and did her surgery. This is how she looks on table. According to me, good. I was sure she's going to heal beautifully, but this is what happens to her after 2 months. Okay. So there is a recurrence. You see, there is a laxity of the skin which has come back. The left eye is doing well, and this is how she presented to me after 2 months. We went ahead and did the repeat surgery, and this is what happened to her wound on its own. It dehisced. It was not responding. And you see the pigmentation has started. She developed a very, very bad pigmentation. Look at it here. So the pigmentation is so severe that we have to now wait and watch for pigmentation to cool down. We are starting her on anti-pigmenting drugs, on sunscreens, and so on. So what is happened here is nothing but the way the tissue has responded to the process. And Shefali, to your question, that's why blepharoplasty patients can be a little tricky. Nothing went wrong with the procedure. There was a recurrence. We went ahead and removed it. The wound is not healing. Then we waited for the wound to heal. And then there is a big scar, fat, pigmented scar, which is sitting. So this is not one of the best results which you want to give to your patients, but these cases can happen, but you should know how to deal with them. So dealing with them is, one is patience. Second, the knowledge of what you're going to do. So you have to treat these scars very, very judiciously with the scar management, with anti-pigmentation and frequent follow-ups. A word on post-op care, which I have not covered here, but I will just talk about it orally, is The post-op care is like any other post-op care which we do. So you have to keep the patients on antibiotics, anti-inflammatory, antacids. I am a big fan of vitamin C and Arnica montana oral for patients. Topically, you have to give them some kind of a steroid antibiotic cream, lubricants, because we know that when we touch the lids, there is a tear film stability which changes, the pH of the tear film changes, so patient has to be on lubricants. And of course, sunscreen is must, because post-inflammatory hyperpigmentation is something which we don't want. So sunscreen can start as early as second or third day of the surgery. I started that way. And then you want the patient to have ice compressions to decrease the swelling. Not a big fan of warm compressions because we don't want anything to heal here. We just want the swelling to come down. So ice packs for 48 hours. And some people do alternate ice and hot colds, which is fine. I mean, hot and cold, which is okay, but then you do the ice colds. And general restrictions, so bed rest for 2 days, light activities for a week, and the follow-up of the patient at day 5, day 7, and day 14, and then 3 months. Based on which sutures you have taken, you will remove the sutures accordingly and keep a close track. And some of these patients may need a retouch-up surgery. Always counsel your patients for touch-up surgery. Some flap here and there, some fat here and there. It's okay. It's not a crime to have that. You can't have perfect result in one go in all the patients. So it's fine. As long as you've counseled your patients, patients will be fine. They will come back to you. They will trust you and they'll get the procedure done. Okay. So this is all about upper lid bleph and different case scenarios, different things which you can get, how to make the markings, how to plan the surgery, how to take the skin and muscle flap, where to take skin, where to take skin flap, where to do the fat. The basics of the fat is to clamp it, cauterize it, and then cut it. Okay, so don't do the reverse. You have to clamp it, cauterize it, make sure there are no feeder vessels which are bleeding, and then cut it. You can use whatever instruments you use, but that's very, very important. Never overdo and never overcorrect any cosmetic procedure, including blepharoplasty. Always undercorrect. If you see, all my patients are undercorrected. If you see, all my results are undercorrected or optimally corrected, and patients prefer that. You don't want to give them an artificial look. You just don't want them to have that cachexy, deep and overcorrected look. You just want them to be themselves, just a smoothened version of themselves. And that's the beauty of doing a natural surgery, giving them that natural results. And that's the art of doing a blepharoplasty, whether it's upper or lower eyelids. I have not touched the brow procedures here because it was not the topic, but always remember, when you're doing the blepharoplasty, it's a unit with your brow, and you may have to do brow lift along with your blepharoplasty in a lot of cases, especially there when there is moderate to severe brow ptosis. And there are ways to do different kinds of brows, which is a topic in itself, which can be discussed sometime later. So I hope I did justice to the topic and you guys had some knowledge inside. And I think we can take the questions if there are any from the audience.
Thank you so very much, ma'am, for such an insightful lecture. We do have a lot of questions from the audience. The first question, if I may proceed with your kind permission, is a preferred technique to assess the amount of skin excision to be made in a case of upper lid blepharoplasty.
There's no preferred technique. It's a clinical assessment. So as we discussed, you have to look at the brow position. If let's say, look at my face, okay? Okay, I have to wear my glasses. So if you look at my brows, if I'm trying to lift it, there is hardly any brow ptosis, right? There is a mild one. I would prefer to have my brows here if I really want to have a wow young effect, but this is not a bad brow position, right? So if I look at now, my lids, I don't know if you guys can see, there is a little amount of laxity here. You see, there is a dermatochalasis which is set in. So this is a true dermatochalasis. Now, when I lift my eyelid up, my eyebrow down, is it changing? No, it is still the same, right? So there is no technique to know how much of the skin is there. It is a clinical assessment. And then when you close your eyes, you can always do a pinch technique to see how much extra skin is sitting over there, because from your lash line to the brow and the skin junction, this is your junction of the skin junction of the brow and lid, okay? Not the brow. The brow skin and the lid skin junction. Till there, from the lash line, you should have minimum 18 to 20 millimeters of skin remaining. That's how you assess upper eyelid skin laxity.
The second question is, ma'am, what is the importance of tarsal platform show?
What is the importance of?
Tarsal platform show.
Tarsal platform show. Okay, that means tarsal show, right? Okay, so this is the instrument which you can use. Oh, somebody mended with my instrument. Okay, so understood the tarsal show? Okay, that's your tarsal show. So if your skin is hooding, if your eyelid is down, especially your eye, okay, I'm on the spotlight. So this is the tarsal show. My tarsal show has increased and people want the tarsal show, especially women, because they want to put their eye makeup. Okay, so if I have a hooding here, my tarsal show will be lesser. You see that?
Yeah.
Okay, if my lid crease is down, my tarsal show will be lesser. So I need to put it up to increase my tarsal show.
All right. Ma'am, role of setting versus supine position during skin marking.
Very good question. You can do both. So you can make the patient sit in a sitting position and see where the lateral part. So basically, why you're interested in sitting is the work of the gravity on your brow, which is nothing but a lateral part of your skin. Medially, nothing is going to happen because the brow is in position. So only to assess your lateral position of your brow and the skin is where you make the patient sit. You can always mark it in the sitting position, the lateralmost part. I mean, see, I didn't show that because I think with experience, we have forgotten that we have to make the patient sit. But yeah, it's a very good question. And thank you for reminding me that, is that you make the lateral marking do in the sitting position. You mark it and make the patient lie down. So you're playing against the gravity and with gravity to make sure you're excising the amount of skin. You can do that, but it really doesn't change your outcome of the markings and the way you're going to do, because if you know your lid crease, you can put me on spotlight. If you know your lid crease and you know from here, from the lid margin to the margin of the lateral flange is 5 millimeters, and from your lateral end to the outermost flange, which you're taking is around 15 to 18 millimeters, it automatically takes care of the lateral hooding. You don't have to do anything.
Ma'am, what precautions do we take while using fulguration?
Nothing. Fulguration is fulguration. You just have to maintain the energy settings. You make sure you're not touching the skin. You make sure there are not pockets which you're fulgurating so high and so deep that patient just jumps on the table. You just have to be very, very gentle on that. And I don't think you have to take any special precautions. I don't know if any of you guys know. Please enlighten me for that.
I think the question refers to the technique that you showed to contract the septum.
Yeah. So no special techniques. You have to keep it on a medium or low energy, which we anyways keep for the lid left. We are not on high energies because we are not cutting. We are not doing anything. We're just sliding the cautery along. As I showed you, the skin, when you stretch and you just put one tick, 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 it just opens up. Okay, even if very thick skin with orbicularis, you just tick, 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 it will just open up. You don't have to do too much of effort for upper and lower eyelid skin. Actually, the mistake people do is they're cutting it as a cake of slice. You don't have to do that. So if that funda is clear in your head, then this question will never arise, because you're just changing the same energy settings to a different tip. And so if this is my septum, okay, this is my septum, I'm just contracting it. I'm not doing. That's not the case. We are not coagulating. We are just sculpting it. We're just sculpting. It's like shrinking it backwards, putting it backwards into the tissue.
Thank you so much, ma'am. That's all the questions we have had for tonight.
Only 3 questions. You said so many questions.
One last question from me, ma'am. Do we I always wonder, when we are doing a young person's blepharoplasty versus an old person's blepharoplasty, any specific points that we need to keep, especially when we are doing for a young person, how they are going to evolve when they age, how much to sculpt, take out the fat, taking out and everything?
Okay, so the thing is, in a young patient, depends on why you are doing blepharoplasty, first thing, because if the patient is suffering from thyroid or any other disease, you know there is going to be fat prolapse. You know there will be laxity of skin. You know there would be muscle changes, right? So that case becomes a case of skin, muscle, and fat. Versus a gentleman or a lady who walks in with just, let's say, blepharochalasis, or a person who walks in with just a skin laxity. As I showed you multiple examples, they're all young and middle aged. Now, people in 20s are not going to walk in for you for blepharoplasty. And even if they do, you have to be careful to select such patients. Based on the pointers which we discussed, there are 3 or 4 pointers. See, your question is, how much should you do so that as they age, they look the way they are? Is that the question? Am I understanding it correct?
Okay.
So if you just follow the principles of the markings, the amount of skin to be excised, the amount of fat to be sculpted, never overdo it, always undercorrect it, always maintain the natural look, you're never going to go wrong. You're never going to go wrong. People may come to you showing some pictures of their own, or with filters, or with AI nowadays, that this is how I want it. You have to say, no, you cannot do it. This is unrealistic. That's why I showed that slide of, unrealistic expectations. Asymmetry is okay. A certain amount of asymmetry is okay. So all these pointers, when you're doing in your counseling, you're assessing. And when you're assessing, you know in your head, is the brow down? If my brow is down, I'm going to lift it up. Is my skin okay? If not okay, this is what I'm going to do. Is there a fat? Okay, I'm going to remove this much of fat. In upper lid, usually we don't do a redistribution or repositioning of fat unless there is a lot of brow ptosis or a brow deflation. Then we can always take the fat from here and put it here instead of doing a filler. So we can do that, but not in young patients. One of the ladies I showed, remember the first and just the immediate post-op wala and then 2 weeks wala, that is a young lady. I mean, she's in her 30s and she does have a skin laxity. So we just went and just removed a pinch of her skin. And in fact, the first time I did, she was not happy. She came back again for more skin. So these patients will come back to you. So when you undercorrect them and you tell them I'm undercorrecting, I always tell my patients, I'm going to undercorrect you. I can do more, but I cannot correct the more to less. It's fine. It's okay. And when you do that, you will never go wrong. And how they age in future is not in your hand, Shefali. The way the aging will happen. And you have to warn them also. Let's say I'm also young, yeah? I'm also young. So today, if I do my surgery in 60s, I may come back with fat pads, and all that. But today, if I do my surgery, I'm a candidate of only skin. Maybe a little bit of muscle, because I don't think I have fat. I don't see my fat. But yeah, there is skin. So nothing is going to change if I turn 60. What is going to change? My skin, so my lid crease is where it is. My skin is where it is. The only thing which may change is the texture of the skin and the fat which may prolapse more. So basic principles of the surgery, of the position of your unit of brow, of your upper eyelid, where the markings are. And last but not the least, I've not touched it here, the skincare, because my topic never stops without that. If you're not taking care of the skin around the eyes or on the face, no matter what you do, your aging is going to be different as you age. Okay, so all these things, when you're counseling the patient, when you're talking to the patients, have to be told to them. That's why counseling is so important. Spend an hour, spend 40 minutes. Markings are so important. I have seen surgeons, my mentor, still today, Dr. Lucarelli, spends 30 to 40 minutes in marking. And sometimes I used to get bored. I said, Mark, do it fast. Now I'm getting bored. He said, no, this is like the most important part. That patience and learning has to come into us to mark it, to be very, very precise. In spite of that, we do mistakes. The markings can go up and down. Asymmetries can come. Basic principles, basic steps, you will seldom go wrong in upper lid blepharoplasty or lower lid blepharoplasty for that matter. Lower lid is easier than upper. Lower lid blepharoplasty is an easier surgery than upper. Okay, because the amount of result you want to give in upper is more complicated in terms of skin, the crease, the muscle. Lower it's bas gaya andar fat nikala. Oh, sorry, you just remove the fat. You want to redistribute, you want to cut clamp. That's it. You're done. But upper lid is more complicated. That's why I was touching upon the skin laxity, the fat, the brow positions, lid laxity. Always look at the lid laxity. Even in your younger patients, if the lid laxity is not corrected, they will have floppy lids. They may come back with lids which are more floppier. So just pay attention to all this. Ptosis, whether it is there or not. What is the position of lash? All that.
Yeah, ma'am. Thank you so much, ma'am.
Okay, good.
Ma'am, before we conclude for today, I have a small announcement to make. We meet next on the 20th of September, the topic being blepharospasm and hemifacial spasm, the Dr. E. Ravindra Mohan.
He's my
This-
mentor too.
Thank you so much, ma'am, for sparing your time. I know you had a very, very busy day.
No,
So
no, not
thank
at
you so
all.
much.
Pleasure. I mean, teaching and sharing knowledge is always pleasure. But I wish I could see everybody because that's much more interactive. But nevertheless, thank you for this opportunity. Always there to be part of the forum and continue.